we have a model, we have a projection, and that's what we follow. The current model, and the model, by the way, even more maddening, the model changes the more data that comes in, because they started with assumptions and presumptions, and then the more data that comes in either affirms or discounts their presumptions that they started with. So they refine the model over time, and the model changes, and the numbers change. But what we're looking at now is the apex, top of the curve, roughly at the end of April, which means another month of this. The apex, the recent number is you could need 110,000 COVID beds. What does that mean? Beds for COVID people, as opposed to other people who are in the hospitals for other reasons. 37,000 ventilators. That is our current model. That model is based on minimum or minimal impact from social distancing. Meaning what? One of the great variables is how effective is the social distancing? Are people doing it? Are they complying with it? And to what extent and how effective is it? Nobody knows that answer. So they do different projections depending on how well social distancing works, how well people comply with it, and then how effective it is. Minimal social distancing impact is where we get the 110,000, 37,000 ventilators. High compliance with social distancing, you still have 75,000 COVID beds as opposed to 110, you're 25,000 ventilators, okay? So when I keep pushing for high compliance on social distancing, it's because high compliance on social distancing will reduce the number. This is what they began talking about, flatten the curve, flatten the curve, flatten the curve with social distancing. This says, this is the difference between high compliance with social distancing and less compliance. If you have high compliance, you're down to 75,000 COVID beds, 25,000 ventilators. Less, it goes up to 110 and 37.